as we understand the mechanisms by which long COVID is happening and how some of these symptoms occur from long COVID, it's a model for how inflammation can affect mental illness.
Welcome to Collaborative Endeavors, a podcast about how experts from different areas of research come together to tackle big health challenges, leading to better therapies and healthier communities. In this episode, we meet Dr. Perry Tsai, an MD, PhD, and assistant professor in UIC's Department of Psychiatry, as well as one of CCTS's newest KL2 grant scholars. One of the benefits of this Mentored Career Development Award is that it offers junior faculty 75% protected time to pursue their research interests. Dr. Tsai shared his ambitions for his project titled Investigating Digital Biomarkers for Post-COVID Cognitive Dysfunction, starting with his professional background and how he arrived at the intersection of infectious disease and psychiatry.
It's a great question, and my answer to it is not totally linear. I started as a undergraduate at Harvard, and I studied biochemical sciences, really interested in biology and biological sciences, and was interested in either going into medicine or research. I really wanted to be able to apply my knowledge in biochemistry and biology towards something that was going to be helpful for helping others in healthcare or researching disease. I took a little bit of a break after college working in a lab, and then ultimately decided to pursue a dual degree program, so an MD, PhD programs. And I had the fortune to be able to attend at the University of North Carolina, Chapel Hill, where I did my medical training, medical school training, and my graduate school training. At that time, I thought I was going to be an HIV doc. Thought I was going to study and see patients with HIV or AIDS. And that's where I was headed for several years. I did my PhD in a research laboratory studying HIV in a translational mouse model, and I absolutely loved it. It was really cool science. We were doing really cool stuff with an in vivo model of HIV, which was quite useful for translational and preclinical studies on HIV. My thesis was trying to look at various strategies for curing HIV. Spoiler alert, I did not cure HIV, but I was able to use our mouse model to try to set it up as a potential experimental model for studying potential cure strategies for HIV. When I went back to medical school, usually with MD, PhD programs, you do a couple of years medical school, you do your PhD work, and then you go back for a couple more years of medical school for your clinical rotations. And during that time, I did a couple of rotations in infectious disease, and it didn't click with me in the way that I expected. But I really enjoyed my time in psychiatry and within that world. As a clinician and on a day-to-day basis, that's what really grabbed me, and that's what really made me feel at home. And so I ended up applying into psychiatry for residencies as my specialty, and also applied specifically to research track residencies, which would offer me protected time to do research and develop my own research profile and portfolio. I was lucky enough to match here at University of Illinois. Over 4 years of 2019 and 2023, I did my training in general psychiatry. I was able to work under one of my mentors here, Olusola Ajulori, who's also an MD, PhD, and has been really prolific in neuroscience and technology, in doing studies looking at the brain and the networks within the brain, as well as working with Dr. Alex Liao, who is using mobile technology and mobile device technology in order to monitor things like mood and cognition. So it's been really fortunate for me to be able to find mentors here who are doing research in psychiatry, and UIC has a really robust department within psychiatry that is doing research on a lot of different levels and has a lot of support and funding for that research. I didn't want to leave behind my immunological background, my virological background, having gotten a PhD in the Department of Microbiology and Immunology, having done HIV research. I was really looking for a space where I wanted to be able to continue to have that lens and use that lens in looking at disease and looking at medicine and healthcare. And what happened was COVID happened. And COVID happened in the middle of my residency. And it affected me in ways that like it affected a lot of people. And then after COVID, the acute part of COVID happened, sort of on a national and global scale. Long COVID then happened after that. And this was about the time that I was finishing residency and about to graduate residency. I had the fortune, like as I was graduating, that we needed a psychiatrist to start seeing long COVID patients because it was a problem that was popping up time and time again with patients who we have a couple of neurologists and pulmonologists and critical care docs and family medicine docs here at UIC who had been seeing patients with long COVID problems, but we hadn't yet had a psychiatrist who had sort of been able to fill that niche. And when I graduated, that's exactly what I wanted to do. It was a space that I could think about an infectious process, a chronic illness due to an infectious process, as well as neuropsychiatric problems from that. And so I have been really lucky to be able to bring those aspects of my training together into starting a psychiatric clinic for long COVID patients, which I've been seeing these patients for a little over a year now. And then also now with support from the CCTS to conduct some research and being able to study these problems in long COVID patients.
A huge investment has been made into research examining the cause of long COVID, what is technically referred to as post-acute sequelae of SARS-CoV-2 infection, or PASC. When most people hear long COVID, they immediately think about the impact to the physical body, ongoing respiratory issues, headaches, fatigue, digestive issues, and more. However, a commonly reported, though perhaps less talked about symptom is brain fog, a blanket term for symptoms that include difficulty concentrating, confusion, forgetfulness, mental exhaustion, and slow process time. Dr. Tsai described his patients' experiences.
Long COVID spans a huge variety of symptoms. Like you mentioned, a lot of people might have persistent respiratory symptoms, but it also spans potentially musculoskeletal symptoms like pain or in the muscles or in the joints. It can be fatigue or sleep disturbance. It can also be psychiatric symptoms. So probably the most common one that we hear is within this realm of post-COVID cognitive dysfunction. And a lot of people describe it colloquially as a brain fog. And this is difficult to define, but is often described as sort of a fogginess or within their thinking, sometimes slowness, sometimes people have memory problems where they aren't able to remember things that just happened or were just told to them. Some people have difficulty with finding words that they have used a lot. And so there's a vast number of ways that cognitive dysfunction can present. And probably about half of patients who have long COVID also report these problems. In terms of other psychiatric problems, I'm often seeing patients who have depression or anxiety, and sometimes this is a new onset in the context of long COVID, or sometimes it's a worsening of their depression or anxiety symptoms they might have had before COVID. And this could be sort of on its own something new, but you can imagine that with all of the other things that are happening within long COVID, it could be secondary to the brain fog or secondary to problems with sleep or fatigue. Or often it can have a psychosocial aspect where a person who has had brain fog is suddenly no longer able to work or no longer able to function in the same way that they did prior to COVID. And that can result in some depression or anxiety about their loss of function or the loss of ability to work. Some people have post-traumatic symptoms, particularly if they were in the ICU or were hospitalized for their COVID experience or their acute COVID infection, Or sometimes people might have lost loved ones and family members to COVID and can have some post-traumatic symptoms from that experience too. So a lot of these different stories, I will say, while a lot of the stories sort of have a similar ring to it, out of my patients, every story is a little bit different too. So depending on your own history before COVID, your experience during COVID, and your current symptoms, everyone has been a little bit different. So I can't say that the same story applies to all the patients that I've seen.
Our conversation pivoted to what Dr. Tsai is hoping to accomplish through his protected time under the CCTS KL2 award, including how this digital intervention can address some critical gaps in care for patients struggling with cognitive dysfunction.
The impetus for this project was this observation or realization that the cognitive testing we have come to rely on to measure cognitive function is usually done by neuropsychologists and neuropsychological testing. And what I had been seeing from or hearing and from talking to our neuropsychologists is that we've been doing pretty diligent neuropsychological testing and cognitive function testing with these patients who have these complaints of brain fog and cognitive dysfunction. But like a good chunk of the time, they weren't scoring below average or with specific deficits in the neuropsychological testing. And there's various reasons that could be. So one of them is that neuropsychological testing typically happens in a pretty controlled clinic setting. So in a clinical office, you don't really have distractions or other things going on in that setting. People might be performing better in that type of setting. Another potential thing is that we often don't have pre-COVID cognitive testing for most of these patients. And so it's possible that they were functioning maybe higher than average prior to getting COVID and now have dipped their function into a normal range. And so it's hard to necessarily see that change. And particularly for people who might have higher demanding jobs or who have a higher level of education or function, a small drop in their cognitive deficit or in their cognitive function might result in them not being able to work that kind of job anymore. This was a discrepancy. This was a discrepancy between the subjective report of what these patients were experiencing. We're not saying that it's invalid, or we're not saying that anyone is misrepresenting themselves, but it's discrepant with what we're finding on the objective testing that we have available. We had this idea to find a different way to measure and to monitor cognitive function. And if we could find something that was potentially more in line with their subjective experience and their subjective reporting of their cognitive dysfunction, this could potentially give us a way to measure improvement if we were to test a treatment, or to at least monitor over time of how these things change. The idea was to find a marker for cognitive function. There's been a lot of literature looking at blood biomarkers. There's a lot of literature looking at neuroimaging markers. So we were trying to develop an approach that we might call digital biomarkers. So I'm using digital technology as a way to develop a marker for post-COVID cognitive dysfunction. And specifically, this would be through mobile devices. Now, the project is going to look at two different ways to use mobile devices to measure cognitive function. One of them is to translate some of those tests that we do with neuropsychological testing into mobile cognitive testing. And so we're going to be working with a company called NeuroUX that has developed a lot of this translation and has worked with other research groups and taken some of the neuropsychological testing cognitive tests that are used and translated them into sort of these games that you can play on your mobile phone. So for example, a reaction time game where when a picture of a dog shows up, you have to tap the screen. And one of the measurements is how quickly you react and how quickly you tap the screen. So that's one example. The benefit potentially of this approach is that we can get measurements of these cognitive tests multiple times in a day and over the span of maybe a week or two. And so it gives us slightly richer data, more data points, but also feasibly takes these measurements more in a real world environment, a patient or participant who is using their phone out in their daily lives. So there's multiple advantages to this approach. The other approach that we're going to take is with BiEffect, which was the app developed by Alex Liao and her group, where they have been able to reproduce a mobile device keyboard that doesn't record any of the content of what you might be typing, but records metadata about how you're typing. So again, not what you're typing, but how you're typing it. And for example, how many times you're using backspace, how many times you're using autocorrect, or how quickly you're typing, or how many pauses you're taking between keystrokes. So a lot of this data can tell us a really rich picture about how you're typing. And they've already been able to look at this as a potential marker for mood. And they've been looking at this in the context of mood disorders like depression or bipolar disorder. What they're starting to do, and what I'm also hoping to do, is using this as a marker for cognitive function. You can sort of intuitively guess that someone who is complaining of brain fog or who's complaining of being a little bit slow in their concentration or their word finding, that they would have more difficulty with typing on a keyboard. And so we are hypothesizing that this could be a useful marker for cognitive dysfunction, maybe more broadly, but specifically going to be in post-COVID or long COVID patients in our study.
Dr. Tsai went on to describe his mentor team and how they are helping to strengthen his skills as a translational investigator.
I have been really fortunate to find some amazing mentors here at UIC. So in addition to Olu and Alex, a couple of other people that I'm going to be drawing on their expertise are Neil Pliskin, who's a neuropsychologist here at UIC, as well as Jerry Krishnan, who I would say is sort of the father of our long COVID clinic and long COVID care, who's the pulmonologist, critical care doctor himself, and has been seeing a lot of these patients as well. Each of these people brings like a really, really great level of expertise and approach to what they do. As I mentioned, Olu and Alex are very much on the neuroscience side. Alex is doing the BiEffect and a lot of the data analysis, which is something that I don't have a ton of experience in. This approach is going to give us a much richer data set, but is also going to require much more sophisticated methods of data analysis. So I'm going to be learning a lot from Alex Liao, as well as her collaborator, Alexander Damos, who's one of the statisticians that they've been working with. Neil Pliskin, neuropsychologist. So as I mentioned, some of the meat of this is going to be in understanding neuropsychological testing and what it means or what it doesn't mean, or what we can conclude or not conclude, and then as well as trying to compare these in terms of their validity, because our gold standard right now is in-person neuropsychological testing. And so we're trying to demonstrate some validity with neuro-UX and mobile cognitive testing in order to compare it with the in-person neuropsychological testing. And then I think Dr. Krishnan, Jerry, has been really supportive of me in joining the efforts in treating and researching long COVID here at UIC. And he has been able to connect me with community partners. He's been able to help me think about how we're going to be recruiting participants. Those are aspects of the study that I was not doing this kind of work before, but I'm going to be learning a lot of those aspects of clinical and translational studies from him and from the rest of my team.
Dr. Tsai has already explained how this study is repurposing a pre-existing technology, BiEffect, to identify digital biomarkers of cognitive functioning in long COVID. But I asked him what could be generalized within these new findings to address future research questions. He was excited to share his thoughts on the translational science potential of this work.
My long-term goal for myself is to be a physician scientist who's looking at mental illness and inflammation. That's something that as I've transitioned from being an HIV researcher towards being a psychiatric researcher, this is ultimately the goal that I want to bridge these two aspects. And inflammation and mental illness, we've sort of known broadly that these two things are connected, but we still don't know how on a more granular or specific level. One of the ways that I'm hopeful this research can contribute to that field is that this is a very specific situation where we have a known infection and then we have known sequelae from that infection. And so it's very likely that inflammation plays some part in this, and that these are the leading hypotheses of how this works. And so as we understand long COVID and as we understand the mechanisms by which long COVID is happening and how some of these symptoms occur from long COVID, it's a model for how inflammation can affect mental illness. And so I'm really, really looking forward to, as we learn more about long COVID, we might be able to extrapolate some of these findings into other diseases or other inflammatory processes and potentially other cognitive problems as well. One of the things that Dr. UL1TR002003 works in is late life depression. And so one of the hypotheses around late life depression, development of late life depression, or relapse of late life depression is that there may be a cognitive decline that precedes this. And we don't always know exactly how that happens, but within neurocognitive disorders or neurodegenerative disorders, there's a pretty strong likelihood that inflammation happens to sort of drive this process. And we've often known about the connections between aging and inflammation, how inflammation starts to either increase or become a little bit dysregulated as we age. And this could contribute to cognitive decline and or depression later on. And so the use of mobile cognitive testing or for the BioEffect could be helpful in trying to measure cognitive decline as well in older populations. And so there's a lot of interesting directions that this could go. And we're not only hopeful about treating long COVID patients, but utilizing some of these models scientifically, but also in terms of implementation in other patient populations.
Dr. Tsai concluded our conversation with a personal sentiment on COVID post-pandemic.
I think the message or the story that I have gotten from my patients and I would like to spread is that COVID isn't gone yet. This is a sentiment that I have gotten from a handful of my patients, on my patients, but some of the stories that I've gotten have really been heartbreaking. And I can recall very vividly one of my patients telling me how people will look at her and tell her, like, aren't you better yet? And it's really challenging for people who have long COVID to describe and to validate or justify their symptoms or their experiences to their friends or coworkers or family, or also to healthcare providers too, because a lot of people will be very dismissive of these symptoms. And while our society has seemed to move on from COVID, COVID is stuck with a lot of patients who are struggling with long COVID. And so I encourage everyone to have a little bit of grace and a little bit of kindness for anyone who says that they're struggling with long COVID. Unfortunately, we don't have treatments yet, but I also would like these patients and anyone who knows them to continue to have hope for treatments that are going to be coming soon in the future.
Collaborative Endeavors is written and produced by me, Lauren Rieger, on behalf of the Center for Clinical and Translational Science, aka the CCTS, at the University of Illinois, Chicago. To learn more about Dr. Perry Tsai and the CCTS's KL2 CATS and CATS affiliate program, visit the links in our show notes. The CCTS is supported by the National Institutes of Health's National Center for Advancing Translational Science through their Clinical and Translational Science Award. Opinions expressed by guests of the show are their own and do not necessarily represent the views of myself, the CCTS, or our funding agencies. You can find more episodes of Collaborative Endeavors on Apple Podcasts, Spotify, Pandora, Amazon Music, and YouTube. While we do not monetize this podcast, we do love positive feedback. If you like what you hear, go ahead and give us a 5-star rating to help spread the word. Finally, to learn more about how you can work with the CCTS to make a positive impact on the health and well-being of our community, visit ccts.uic.edu or follow us on X at UIC-CCTS. In some exciting news, our friends in UIC's Department of Community Health Science just dropped their new podcast series, Community Level. We think people in the public health sphere will really enjoy hearing from their guests. A quick plug coming up now.
Welcome to Community Level, a podcast where public health research meets real-world impact. Brought to you by the Community Health Sciences Division of the University of Illinois Chicago School of Public Health. I'm Dr. Kelechi Bay-Lamberts, your host, and each month we'll bring you in-depth interviews with leading academic researchers, community leaders, and organizations making a difference in our communities. Discover the groundbreaking projects and innovative solutions that are shaping the future of public health. Their personal stories and professional journeys that led these experts and community leaders and scholars and students to their vital work. At Community Level, we go beyond the data to explore the human side of public health research and community initiatives. Whether you're a student, professional, or just passionate about making a difference, this podcast is for you. Join us as we bridge the gap between research and practice, one episode at a time. Subscribe now on your favorite podcast platform and follow us on social media for the latest updates. Let's make a positive impact together at the Community Level.